is how to set up the OR for trauma bay, for traumas coming in. Basically, if you're working in a trauma center, you must have a OR available 24 hours a day at all times. So once a patient comes into that trauma room, you must open up another trauma room that stays vacant and ready for the next trauma to come in. Okay? You really need to set up the room fully before you start. Okay? So at least in the time that we were doing it, we had all our drugs already drawn up, ready to go. There was no way of having to draw up the drugs when you got called. You didn't have the time. So we set up all our medications, and then we had the times actually on them. We used pentothal most of the time in those days, and propofol is very rarely used for trauma. So etomidate is available as well for these kind of cases. So you have those drawn up in individual syringes ready to go. You always have a difficult airway cart in the room. Okay, all the fluid warmers are set up and ready to go. They already have tubings in them, the warmers are set up, and they're actually on. You have 2 IV poles, and you have a procedure in what's called an invasive line cart system, which means that you have separate carts to do specific things. So you have your difficult airway cart, and then usually we'd had a central line cart, and then we have our arterial line cart as well. So you would always be available with lots of material in case you had to do different things. This is a typical setup for an OR. Okay? This is showing you how a normal setup is. You have the OR bed, 2 IV poles in place. Okay? This one doesn't have the IV warmers set up. The anesthesia machine's on. It's been checked off and ready to go at a moment's notice, and you have all your medications over here. Now, the real critical part, the way you can tell somebody really knows what they're doing in a trauma service is that you see that everybody has their assigned task. Okay? And you really have to establish that beforehand. Everybody plays an important role in managing the patient, and the more used to having a system in place, the faster it goes and it's better for the patient. What you end up having is you have what's called a team leader first. That team leader usually is the most senior person in that room. Usually that person involves and makes all the decisions as well as manages the airway most of the time. And then usually they have, when you start the case, at least 2 assistants. Okay, so you have a total of 3 anesthesiologists and nurse anesthetists that are all working together. If you work in a level 1 trauma center, there's lots of people around. Usually not an issue. If you work in a level 2 or level 3 trauma center, I make phone calls. If I hear I got a major trauma coming through the door, I pick up the phone and call my partners, or I call for extra help from other CRNAs, either in obstetrics or somebody else, so they can give me a hand. Okay, you can't do this by yourself. It's just not possible. You're just not going to be fast enough to do it. So you really need assistance. Now, on arrival to the OR, you immediately place all the monitors on the patient. Invariably, trust me, it's chaos. Everybody's yelling. People are in a constant state of movement. And what you have to do is calm everything down. Okay? So you tell people, assign them duties. One guy does the blood pressure cuff. The other guy puts the pulse oximeter in the other hand. You put the EKG pads in the top of the head. Okay? And you transfer the patient safely with lumbar and spine stabilization, and you transfer the patient if you think that there's some kind of injury there. Then you make sure that you have good IV access. Okay? You must have at least 18-gauge IVs, at least 2 of them. Okay? If you only have 1, then you put the person to sleep with 1, and you get another one in. Okay? One of the biggest frustration factors for us in the trauma bay was that somebody would stick somebody 20 times in an arm, and it'd shoot up all your veins before you even had a chance. Okay? So our deal was with the nurses in the ER was, if you can't get it on the first stick, you're allowed to do 1 more stick, and that would be with a 20-gauge IV. And everybody's going, what, 20-gauge IV? Yeah, that's fine. Just put them a 20-gauge IV. So they would, and what will happen is when they get to the trauma bay upstairs in the OR, we'd put them to sleep, we get another IV in them, usually because everything vasodilates on induction, so it makes it easier to put an IV in. And then we'd take that 20-gauge IV and convert it into a 7.5 cordis, okay, or a 6.5 cordis, so which is a pretty big size cordis. You just put a wire through the 20-gauge IV, you put the 20-gauge IV out, you have that area prepped and draped, and then you put your introducer in, and now you got this huge IV in place. So that worked out really well for us. After you have the IVs that are confirmed, and you need to put an A-line after you secure the airway. The airway management usually preceded the A-line placements. Okay, so once you got the person intubated, then immediately your assistants went to each arm. Okay, and both people were sticking at the same time. Okay, so as soon as the person got the first one said, "I got it," then the other one would desist from what they're doing, and now you've got an A-line and another patient almost immediately. Usually in about 3 to 4 minutes, you had somebody monitored, intubated, IV'd, and A-lined, ready to go. Airway management, of course, is critical in different situations. You've got to have all your equipment readily available. The glide scope has really made a huge difference for us clinically here, and if you do end up working in a trauma bay, that's something that I would recommend you buy as well, or have somebody purchase for you guys. Charting and drugs are secondary. I mean, just charting is. So drug-wise, you have to give your induction agents to keep the person hemodynamically as safe as possible. Avoid narcotics initially, trust me. A lot of people think that narcotics are really a stabilizing agent. It's the worst possible thing to give somebody who's sympathetically mediated, because then you'll knock out the sympathetics and you won't have a blood pressure in your hands. So I almost don't ever give narcotics until I know everything's very, very stable. Okay, instead I use volatile anesthetics, which I can go up and down on, and if I think the person is not going to tolerate even that, then I give them scopolamine, 0.4 milligrams to 0.8 milligrams IV. That scrambles their brain. You don't have to worry about it at that point. They're not going to wake up for 8 to 12 hours anyways. Okay? Fluid resuscitation, of course, is critical. Okay? The important part is you've got to have enough IV access, depending on the extent of injury that you're dealing with. Do not put anybody to sleep without IV access in place. Okay? If the surgeon tells you, "Oh, I need to cut this guy right away," so you get the IV after you put him to sleep after I cut. And the answer to that is absolutely not. Okay? Never, 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 never let a surgeon cut into the belly without you having adequate IV access. Because the abdomen is acting like a tamponade. Okay? It's compressing against the splenic laceration, and it's keeping that person alive. As soon as the surgeon opens, and I've seen this, blood just goes all over the place. If you have an aortic injury, you'll see it hit the roof. Okay? If it's just a splenic injury, you'll see the blood just pour out of the belly, and it's like watching Fantasia with Mickey Mouse trying to get the water back into the well. Okay? It just doesn't work for you. Okay? So you better make sure you have good IV access. And if you can, get a cell saver to spin the blood and hopefully give it back to the patient. So fluid resuscitation is vital, and you must have good IV access before you do that. Okay? The other big enemy in trauma is cold. Okay? Hypothermia is a huge enemy. You have to keep people warm. Nothing that makes me more angry than have a patient come from the emergency room and the person has been given 4 units of blood in the emergency room. And when asked, "Did you warm the blood?" and they give you that glazed look like, "No, do I have to?" Well, yeah, when you put the patient to sleep, they're 32 degrees. You're in a really bad place at that point. Okay? They haven't resuscitated, they just killed the patient, is my attitude to that. So I've always told people, don't give them blood in the emergency room if you can't give it through a level 1. Keep the patient warm. Don't do that to me. Okay? And don't do that to the patient. IV access, this is what we call the conversion device that we use, okay, which is a RID catheter. RID stands for Rapid Infusion Device. Okay, RIDs can have a wire, which is right here, that you use to put through the 20-gauge angiocath, and this is a 6.5 French cordis that will then go through after using the dilator. The trick to this is that you must put a tourniquet on the patient first, prep the IV site, and then put the 20-gauge the 20-gauge, use the wire to go through the IV catheter, and then you remove the IV catheter. Then you take the small scalpel and make a small scalpel incision at the skin, and then you take the wire, holding it using what's called Sellinger technique, and just slide the cordis and dilator through without letting the wire go in with it. Okay? If you do that, then it's like running a train on a railroad track. It goes right where it needs to be. If you push the wire and then the dilator together, the wire will bend and it will cut into the vessel, and you won't know where you're at. Okay? And trust me, when you do get into the vein, when you take the dilator out, you'll know it. there'll be blood everywhere. Okay? So you'll connect up your IV at that point, and you got this really nice system, the RIC catheter or the RID catheter. Some of them are called rapid infusion devices, some of them are called rapid infusive catheters. So it depends on which kit you have. We also here have what's called the aerotrauma kit, which is where I was trained at. That's where I love that little sucker, and that's what this is right here. Okay? The RIC is not like a normal central vein catheter. It is huge. Okay? It's what we can actually do dialysis with it. So you really have to be experienced when you put this thing in, because you can really do damage and really hurt somebody. So the trauma kit's great, but it's dangerous in inappropriate hands. If you have a choice between using a quad lumen and a cordis, don't waste your time with the quad lumen. I know it has more lumens, but they're all high resistance systems because of the long tubing with narrow things. So you're better off by having a cordis. Okay? And the cordis, when we actually did our studies, showed that the cortises in the older days would have a 90-degree turn in them, which would slow the velocity of blood transfusion considerably. The new 9.5 French cortices have this bypass mechanism that doesn't do this 90-degree turn, so you can actually give blood very, very, very rapidly through that. As soon as you put in a PA catheter through the cortisol, it begins to slow down the velocity of blood transfusion. So I would not be putting in a PA catheter. That's what you're going to be doing. It's a lot of resuscitation. Just leave the cordis alone. Put the cap on it. There's a blue cap that comes with it to occlude the actual valve. The reason you do that is invariably it doesn't fail very often, but if you do it under a tremendous amount of pressure where you're actually using a machine to push in the blood in the patient, that valve will actually leak and you'll start getting blood out of that, which is something you don't want to see. That happens very, very rarely though. So here, this is what I was telling you, never, never start a case without adequate IV access. This is a splenic rupture, this is a liver rupture, okay? And you can see all the blood that's inside this guy's abdomen. This guy is not normally that rotund, okay? This is actual bleeding inside. When you always know it, when you touch the person's skin, it's like a drum, it's super tight, okay? That's usually a bad sign. And I'm telling you, when you open up the belly, you're going to go like, whoa, I didn't realize anybody could lose that much blood that fast. And they'll fill up the canister with 2.5, 3 liters in a quick instant. Induction sequence, assess your airway, just like any other way. Okay? You're not going to be able to do flexion extension exams a lot of times because most people are on C-spine precautions, so they're going to have the Philadelphia collar on them. Okay? But one of the things that's really, really important is that the collar is there to help you when the person is in restraint, okay, when they're moving them around. But when you're trying to intubate them, that collar is going to be your enemy. Okay, you cannot, or you will have a very difficult time intubating somebody if you keep the anterior portion of the collar in place. So one of the things that I recommend you do is that you have somebody doing inline stabilization, which means they take both their hands and hold the person's ears. The old days we used to do what's called inline traction, which would be pull on it. That's found to actually cause injury, so we stopped doing that. Instead, we do inline stabilization, okay? And then you take the anterior portion of the collar off. Now you can actually, when you move the airway with your blade, the actual mandible will move in its normal way, and you'll be able to intubate the patient. So make sure that you take the anterior collar off. Once the patient's intubated and secured, okay, then you put the anterior collar back on, okay, and make sure you put it on appropriately. Make sure you're not pinching skin or something like that. Confirm that all your airway equipment is functional. And invariably, you know what, you'll check your blade and everything's fine. As soon as you do get your rapid sequence, you're all hyped up. It's like the adrenaline sort of goes on to the laryngoscope, like it blows out. And you open up the blade and the light's out. And you're going like, I just checked it, you know. Then, of course, your excitement level just goes up quite a bit. That's why you always have 2 blades. You always have your backup blade in case something like that is going to happen. There's a whole thing called Murphy's Law. If it can possibly happen, it is going to happen, okay? And trust me, I've seen it happen so many times that we actually, as residents, we would actually carry pouches with us all the time. Okay? Everybody knew who the anesthesia residents were in our hospital because we invariably always had butt pouches on us. And in the butt pouches, we had endotracheal tubes, we had succinylcholine, we had etomidate, and we had our 2 or 3 blades with battery holders on them. Because invariably you get to a code, which we were responsible for all the codes there in that hospital. You would get there, the trauma kit would open up, and you'd find that the blade wasn't functional, the battery wasn't any good, and you would be no equipment to intubate somebody with. So all of us started carrying our own, and including underneath our pants here, we would carry Eschmann stylets underneath. So we would had those readily available to intubate. So you will develop these different ways of doing things to make sure that you can do things safely in your own theater where you work at. Induction is simple, and I'm going to go through that very specifically so you make sure you get these maneuvers properly. You pre-oxygenate everybody, okay? The reason you're pre-oxygenating, it is detrimental to the lung in the sense that it causes more atelectasis, but the benefit to you is that it gives you more duration and time before you intubate, before the person desaturates, okay? If you don't do a pre-oxygenation appropriately, the person will desaturate in anywhere between 3 to 5 minutes. If you do it appropriately, you can actually have a duration of anywhere between 8 to 15 minutes, depending on the health of the lung, okay? The way you actually know that you properly pre-oxygenated somebody is by monitoring their end-tidal O2 concentration, okay? If you see the end-tidal CO2 concentration achieve greater than 85%, that person is more than adequately pre-oxygenated under normal conditions. If you really want to be patient, you want to wait all the way up to 95% or excess to exceed. Usually that will be done with 4 to 5 forced vital capacity breaths. If not, you're going to be pre-oxygenating for at least 2 to 3 minutes in normal tidal volume breaths. Okay, just so you know it takes time. Initiate your cervical spine stabilization, remove the front collar, then apply cricoid pressure simultaneous to the medications. If the person actively begins to vomit, you must release the cricoid pressure immediately and put this person in a lateral position and let the vomit drain out of their mouth. Because at that point, they're still awake. The reason you're doing this is because cricoid pressure is only for passive aspiration. Okay, it's only for passive vomiting. Okay, because what happens when you put the person to sleep is the lower esophageal sphincter relaxes and lets vomit come up passively. But active vomiting can generate as much as 300 millimeters of mercury in pressure. And if you don't believe me, okay, if anybody has kids, okay, just feed them a little extra and watch how they vomit, and it hits everything in the room. Okay, and you're just like, how could somebody vomit that much? One of my friends, we kept telling him for years, don't get so close to the patient. You know, he's right on top of them. Okay, and one day in the trauma bay, and we're all back here when we're intubating, you know, because we've been experienced enough. And the guy had gone to the spaghetti warehouse and decided to have a few beers and vomited all into his face, and he's taking spaghetti out of his glasses. So, not recommended. You don't see very well with that, okay? So make sure you keep your distance, okay? Anyways, you put your cricoid pressure and you hold it until you confirm end-tidal CO2 plus breath sounds bilaterally. So part of the ideal maneuver is to make sure that your breath sounds are not only bilateral, but also that you have end-tidal CO2 confirmation. The induction medications, of course, are sedative hypnotics. Usually etomidate is being used as a majority. Also ketamine can be used in some situations. Diprovan, sometimes very rarely, and as well as pentothal. Those are rarely used because they have so much vasodilator effects. So it's really most of the time we use etomidate. Laryngoscopy, if you're really having a poor view, you can do what's called the burp maneuver, which is backward, upward to the right pressure. So you can actually displace the trachea upwards and towards visualization, which can improve the visualization by 1 grade, okay, which is There we go. Okay, is that better? So make sure that you when you endotracheally intubate somebody that your CO2 is present. Okay, anything else is not appropriate. Vapor in the tube means nothing. Okay, breath sounds mean nothing. Okay, seeing the tube go through the cords means nothing. 15% of the time when you actually think that you've gone through the tube, through the cords, you're not still in. 15%. And that's with people that are highly experienced. Okay? With you guys, forget about it. It's 50% of the time you won't know where you're at. Okay? So that's normal. Okay? That just comes with time. You know, I can show you pictures all day long of the larynx, but until you actually get exposure to it, you're going to go like, man, this is a lot harder than I thought. Okay? And it takes time. And after you're doing it for about, a few years, you'll get better at it. Okay? So be a little bit easy on yourself as you're learning, and also be patient with yourself that sometimes it takes time. Now, there's other people in this room that actually be naturals. Okay? They'll get a laryngoscope in their hand, and they'll do it like they were born with it. And guess what? They're lucky. Okay? But that's not the majority of us. Okay? As soon as that you know that your end-tidal CO2 is present, plus breath sounds are equal bilaterally, and the way you listen to breath sounds is not the anterior chest. You have to listen to the axillus. Okay? That's why you know that you're separating the two lungs. If you listen to the anterior chest here, you may actually be in main stem, and you'll still hear referred sounds, which makes you think that everything's okay. The other thing that you don't want to do is you don't want to have your buddy listen to the right, and you listen to the left. And I'd say that's really kind of cute, but you know what? Unless his ears are connected to your brain, you really don't know if it's equal. Okay? So don't do that either. I saw that done the other day, and I went a little bit nuts. And I main stemmed the patient on purpose. I said, okay, now tell me, do you hear a difference? And the guy goes, no, because I'm not listening to the other side. I said, that's my point. Okay? So don't do that. Okay? This is what inline stabilization is. Usually in inline stabilization, the person that's stabilizing is between you. Okay? They're below you, underneath you. Their head's usually here, and they're holding the neck. They can't see what you're doing. Okay? This picture is nice, artistic view, but there's just no space. Okay? So the guy that's really holding inline stabilization usually is on his knee and holding on to the person's head so it doesn't move. Okay? And that's their whole job. Okay? The other guy on the other side, which is your secondary assistant, is holding cricoid pressure, and usually he's the one that's pushing the medications. And then you're the one that's intubating if you're the team leader. Okay? Make sure that you always have your stylet in your endotracheal tube to make sure that you don't have to struggle to get the tube in. Should you place an NG or OG tube? Okay? And the indications is mostly trauma. The thing you have to remember is that it does not remove particulate matter. So if the guy just had a big lunch, guess what? It's not going to help you. Okay? I had a case where a guy went to Spaghetti Warehouse, and he decided to get into an accident because he had not only a whole bowl of spaghetti, you know how big those big bowls in Spaghetti Warehouse, but he filled himself up with also eight bottles of beer. Okay? So, big surprise, he hits the bridge abutment on I-4 and ends up coming into Tampa General. Okay? What was rather interesting is that once we got into the guy's abdomen, we had him a stable induction, the patient began to hemorrhage to death from a splenic laceration, and the surgeon couldn't get to the spleen. The stomach was so distended full of spaghetti that he could not get to the spleen. So the surgeon was freaking out, saying to me, get this guy's stomach emptied. And of course, we weren't thinking, because I was still pretty green. But we put an NG tube in. That was a waste of time. We got a little spaghetti sauce back, but that's about it. So the guy says, you've got to empty the stomach out somehow. So we put in we couldn't find anything large. Okay? The only thing we called for was an E-wall tube, which was down in the emergency room. E-walls is what we use to empty out people that have poisoned themselves by lavaging their stomach, which that works great. But in the emergency room, that's where they usually hold those. We found that that's why we had to have one in our trauma base. And after that, we incorporated that as part of the equipment that was vital in our trauma rooms. But in the interim, since we didn't have it available, what would look like an E-wall tube? Chest tube is what we use. And the endotracheal tube is not long enough. So we put a straight chest tube under direct laryngoscopy, put it in very smoothly, and all of a sudden we hit the mother lode. And it was kind of funny. The surgeon squeezed his stomach while we were doing this, and just the spaghetti came pouring out of his. So it was actually a great picture. I wish I had it still. Some of my friends have it. So I was standing beside it and looking at him like the guy's covered in spaghetti. It's like one of those weird days we had. But the guy survived, which was pretty good. The things that you got to be really careful about is NG tubes. Is that if you have a basal skull fracture or cribriform plate fracture, you can actually get the NG tube into the brain and then suction out the brain. That's not a good conducive to survival. So I would not recommend doing that. That's why you put an orogastric tube in them. Placement of esophageal is placed always after the NG tube. Okay, please do that. Don't do it the other way around. I had one time one of my friends who I got called in to give him a hand because he had taken the NG tube and put it in after he put the esophageal stethoscope in. And after he put it in, he couldn't find the esophageal stethoscope. What happened to the esophageal stethoscope? It went into his esophagus. Okay, so I got the lucky job of going in there with fiber optic because I was an ICU doctor at that point, was a fellow. Went down there, looked for it, found it inside the esophagus, and grabbed it with a set of tweezers, and we pulled it out. Okay, but again, something you learn. Don't put the esophageal stethoscope after. Do it after your NG tube, not before. It's a good thing to have because it measures temperature very accurately. And it's good also because you can listen to breath sounds, which is something you should become very much in tune during cases. Hypothermia is your biggest enemy in the trauma bay. Mortality rate is high as 53% in patients with core body temperatures of less than 32 degrees. Look at that number. If that doesn't impress you, then nothing else should. Okay? 53% mortality rate if you get somebody below 32 degrees. So if you give somebody 4 units of blood, you're going to drop them by 1 degree per unit. So what's their chance of survival at that point? 50%. Okay? So don't do that. Or if you're seeing people doing that, tell them to stop and show them this number because that's really a bad number. Okay? Problems with hypothermia is that you get into coagulation problems. Patients will just continuously hemorrhage on you. You can't get it under control. One of the interesting studies that was done in the trauma services is that we actually gave up on trying to control their hemorrhaging. One patient that came in had extensive liver laceration, and the guy was 31 degrees. And the surgeon said, you know what, we're not playing this game today. He put the laps in, closed them up, and took him to the ICU. And everybody thought he was nuts. Okay, he said, nah, this guy's going to die. So all we did for the next 4 hours in the ICU was warm the guy up. Got him up to 35 degrees, and then took him back to the operating room, and then fixed his liver, and guess what? He actually survived and did fine. He actually got very little blood transfusion. Okay? It was rather impressive, and they did subsequent studies on that, and they found that it is the best thing to do is if you get somebody that cold, just take them back, rewarm them, and then bring them back to the OR. You have a much better outcomes as a result. Myocardial dysfunction also takes place. Hyperkalemia becomes a big issue. Invasive constriction can sometimes cause very prolonged shock reversal to take place, which again is not something you want to see. Warming patients can be done with blankets. Yes? No. Yeah, you try to rewarm them as fast as possible because you need to go back to the OR as soon as you can. Now, there's, of course, studies that show that hypothermia is useful in somebody who's cardiac arrested, but that's different than what I'm talking about here because they're not hemorrhaging. Okay? Hemorrhaging requires these little proteins to be working properly. Okay, all those factors that you have in your blood that the coagulation cascade is made of, as well as calcium, is critical for the clotting to take place. And if you induce hypothermia, those proteins denature, and then it doesn't happen. Okay, it won't work properly. The platelets don't adhere properly. Everything goes to whack. So if you have somebody hemorrhaging, warming them up is vital. If, on the other hand, somebody has developed a cardiac arrest, keeping them cold may actually be improving their survival. So you have to look at what you're dealing with. Okay. You have fluid warmers, fluid blankets. The biggest fear with fluid blankets, and we almost got rid of them all, is because patients were actually waking up with burns, second-degree burns to their back, because the thermistors were going out of whack, sensors were going bad, and invariably we just got rid of them. Now they're coming back because they're finding that they have new, better thermistors that are not failing. What we went to in the 1980s was this, which was called bear huggers. Okay? And bear huggers are great devices as long as you use a warming blanket. Please, 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 do not just take the tubing and put it underneath a blanket and think it's going to work. Actually, if you do that and it touches skin, it'll burn the patient. Okay? It can also cause other bigger problems in the sense of not only causing burns, but there's been supposedly reported cases of a fire one time with it. Although I don't know how it could do that, but you know, most likely it was alcohol around it and it induced enough heat to cause a fire. So make sure that you're using an air blanket. That's what dissipates the temperature across the chest, and it works very, very nicely. Most of the heat losses occurs though where? Head. Head is where most heat loss is taking place. So make sure that you cover it in plastic like this guy is, and that way the air warmer goes upwards and covers the head and keeps the guy warm. Okay. Fluid warmers, you have plate warmers, which is like the Ranger. The only good thing about that is it can only deliver around 500 cc's per minute before you're becoming an issue. So if you're losing 3 liters per minute, the Ranger is just completely overmanned. So don't use that device. You really need to use what's called the level 1 warmer. Okay? The level 1 warmer is an automated pressure chamber in the top. They used to have to be hooked up hydraulically. Now they're hooked up to the electrical system. So now you can actuate it without having to also hook it up to the pressure system, which is kind of nice. It has a water bath in it that runs inside a tubing that's made out of metal, and it keeps the blood very warm. You can deliver about 1,000 cc's per minute without really having any problems. Okay? What's really cool is coming down the pack is this new thing called electromagnetic warming. And the military is using this now extensively because this doesn't require you to have any kind of fluid bath. Instead, it actually spins the blood and heats it in the process, and it's very, very efficient. You can actually push 2,000 cc's per minute through it, supposedly, without causing any degradation in temperature, which is pretty impressive. As you can see, this has a huge canister where you can pump a bunch of blood into the canister so you can spin it into the patient very effectively. Okay? Really cool device. I wish we had one of these. We don't really need it right now at this point because we're not at level 1. But if I was in a level 1 center, this is one thing I'd ask for. Pressure infusion bags are critical. The problem with them is they can generate a pressure of excess of 300 millimeters of mercury. And nothing worse than when you squeeze the bag too much and the bag blows up. You get showered in blood. It's kind of not a good thing. The surgeon's usually not happy because, of course, you just blew the surgical sterile site when you do that. So try not to do that. Be very careful when you use it. There's hand-operated ones, which is this one, and automatic. The automatic ones are here. Make sure you look at the design. When you open up these wall things, these units, look at the underneath. This is a label right here. Look underneath the label. You'll see a little hanging point. That's where you put the blood at. The other hanging point is on the top, and that's for the saline bags. Okay? So you want to put it on the smaller little hook in the back in the middle because that gives the connection point to not be inside the pressurization so it doesn't get kinked. Okay? And it works more efficiently. One of the things that I always teach you guys when you start giving blood transfusions is to make sure that you dilute blood down. The hematocrit in the blood in the bag is at least 80, 75 to 80 hematocrit. That means there's very little plasma in there. Okay? And the normal hematocrit in your bloodstream is around 40. So what we tell you guys to do, and most red blood cell comes in 250 cc's. So we tell you to take 250 cc's of normal saline and push it into the bag to dilute it down to a hematocrit of 40. And that works really well to be able to infuse it quickly and also brings the hematocrit to a more normal level in the patient. Okay? The other good thing about doing that is that you invariably have a higher level of potassium in blood that's been sitting in storage, so that dilutes out the potassium effect a little bit, and you get a little bit less hyperkalemia with it. Okay? Do not let lactated ringers go into the packed RBCs, because lactated ringers has what in it? It has calcium. Calcium will actually cause a stacking of red blood cells together called the rouleau formation. Rouleau formations are not visible unless you do it under microscopy. And the bad thing about rouleau formations, if you start doing that, is you start causing microembolic phenomena in the lungs. So you may end up getting ARDS in post-op day number 2, and you're wondering why. Establishing of an A-line is something you're going to learn while you're here. You are not allowed in this program to ever touch a brachial artery. Okay? You may see other people do it, but you as students are never allowed to do that. It's one of the few things that I will teach you never to do. I've seen people do it, and I keep telling them they're nuts. Okay? The reason I tell them they're nuts is because of this picture. This is what happens with somebody who's been, has hit the brachial artery. They lose their hand. We had a huge lawsuit up in Tampa with an artist, okay, that came in a trauma accident, and he survived the trauma, but he didn't survive his hands. Okay, his hands both got amputated because somebody decided to put in a brachial A-line in them. Okay, attempted on both sides, and both sides completely clotted off, and the guy lost both his hands. On an artist. That's how he made his living. Not something you can do. Okay? So brachial artery is an end artery, so as a consequence, you really shouldn't be messing with it. You should use the radial A-line because the radial artery is the non-dominant artery of the hand. It's not the dominant artery of the hand, it's a non-dominant. Okay? The dominant artery of the hand is the ulnar artery. Okay? Axillary artery is a very large artery with collateral flow around it, so you can put an A-line in there very safely as well. Femoral A-line is also very safe to do. Okay? And indications, anytime you think you need it, just do it. That's as simple as it gets. Okay? Because if you think you're going to have to draw multiple lab draws, you better have an A-line. Okay? You don't have time to waste having to stick the guy in his veins when you're actually infusing it below, and you just won't get a good accurate reading. Okay, so get an A-line in early. This is an A-line setup. Some of you guys will be discussing that at another point. So, just know how an A-line is set up properly. Make sure that you don't have any air in the system. If you do have air in the system, you de-air it. Okay. How long should you pull on the pigtail? Less than 3 seconds. Now, the question is, do you know why? It won't rupture. Okay, you got part of it. Okay, what will happen is when you pull on that pigtail, it generates 300 millimeters of mercury pressure into that artery. Okay, if you have air or any kind of debris in that artery, it'll get pushed back upstream, and around 5 seconds, it'll reach the internal carotid artery, and it'll then embolize to the brain. Okay, so that's why you don't do it. Okay, so 3 seconds is the maximum time you should go. Because then, if there's any air or anything, it'll go up to the brachial artery and then it'll come back. That's about as high as it's going to get. Okay? Of course, the more hypotensive the patient, the more backup there's going to be. So keeping it at 3 seconds is about right. Okay? Keep up with fluid resuscitation. This is one of my pictures. This is one of my active days, having a good time. This was a good time where I was at. Okay? You can tell this is a major case. Okay? You start stacking the blood on the floor, you know you're having a considerable case. Okay, this is what's called the waste field. The waste field will tell you exactly how many units you're administering. We usually would stack 5 per, so this guy's got 5, 10, 20, 30 units so far, at least maybe another 10 units here. So we're looking at maybe 50 units that this guy's gotten so far. Hardly anything, right? You're pretty busy that day. By the time you're finished, you're tired. Okay? Make sure you keep up your fluids, 3-to-1 fluids. Okay? Once I give above 5 liters of crystalloid, I stop giving crystalloid at that point, or slow it down. I give mostly packed RBCs and blood at that point. It's not going to do you any good. All that crystalloid is just going to go in the third space and cause more problems. So I tend to give blood. If you're losing blood, give blood. For every 4 units of packed RBCs, you start giving FFP at that point. Usually before that, you don't have to give FFP. It's once you start exceeding 4 units of packed RBCs that you really need to start giving FFP. Usually it's given at a ratio for every 4 units, you give 2 FFP. So, and that's how you keep up. Platelets, I don't like giving. because invariably it goes into your lungs and it causes ARDS in a very high frequency rate. So does FFP too, but of all of them, I think platelets are by far the worst of these culprits, because where do platelets come from? When I tell you that there's 8 units, what does that mean? It usually means it comes from 8 donors. Okay, so that's a lot of people. More people, more white cells that are in there. It's supposed to be scrubbed to the white cells, but invariably something gets in there and you get problems. And that's why the person reacts to it and forms this inflammatory mediated reaction in the lung. Yep. The iron levels or ion levels? Iron levels actually go up. As you transfuse somebody, the free amount of free iron it breaks from the red blood cells is increasing. You can't really do very much about it. You know, it's a concern because it causes vascular injury. But the ion that's really critical is calcium that's dropping. That you have to replace. The chelating agent inside the red blood cell package bag contains citrate. Okay? And citrate is not inactivated at that point, but once it gets into your bloodstream, it is inactivated. But before that happens in the liver, it binds to a lot of the free ionized calcium that's in your bloodstream. So your calcium levels can deplete very, very rapidly. And the person's coagulation cascade, which requires calcium as well as your muscle control, including the muscle control of your heart, becomes significantly impaired. So, yes, sir.
I was just wondering when you start to worry about the patient's ABO type changing with so many units in someone else's blood.
4 units, and once you go into 4 units, you stay on just a donor. Donor-free blood, which is O. Okay, once you exceed 4 units. So most of us will actually wait, if we can, for the ABO group subtype. But once you get into more than 4 units, you don't switch back. So you keep it on O at that point.
So you kind of aren't concerned with what the original title was then after that?
Nope. You sort of stay where you're at with the O type. You're more likely to have blood incompatibility reactions if you start switching back again. So, depending on if it's a trauma center, they'll have 180 to 200 units. So you can empty out the bank in a hurry. And then, you know, in the military, you have to make a hard decision. In the military triage, it's a very different world. In the civilian triage, you take care of the sickest first. In the military triage, you take care of the people that are going to be able to go back to fight first. And you take the people that are going to die, and you just tag them, impending. And you don't do anything. You give them morphine, and you keep them comfortable, and you let them die. You don't have the resources in the field to take care of one guy when you have to take care of 20 guys with the same amount of resources. Now, you may think that's harsh, okay? And some people do, and they find it objectionable. But I'm telling you, if we ever get into another 9/11, we were very fortunate in 9/11 in the sense that everybody died. Okay? We had people that survived. This system would have broken, and you would have seen it real fast. And they would have had to do the same kind of system, which is the civilians are not trained properly on how to triage that way. Okay? And you're going to have chaos. Because then people are going to have to make decisions saying, you're going to die, and the people that are military trained will do it very easily, not thinking about it too much, because that's what's necessary. Okay? You may not, you know, sometimes you don't really think about all these disasters, and they can occur even in urban environments from like major earthquakes. So if you end up working in California or something, you may end up seeing something like that. When I was in Nicaragua, the big earthquake hit there. All their nursing staff and all their physicians went to the hospital. Okay, immediately taking care of people coming in, and not enough. You know, they should have put a field tent up immediately. Instead, they were actually working inside the hospital, which was foolish. And sure enough, in the secondary quake, 6 hours later, the building came down on top of them and killed all the medical personnel. Okay, it killed almost all the doctors in all of Managua and all the nursing staff. So they were in a real bind then. Okay, now you had no hospital, no equipment, nothing. So, if you do get in emergency situations like that, and you're in an earthquake-prone environment, get the hell out of the building, get yourself set up in a field tent outside and deliver care outside. Because ultimately, without you, it's not going to do you any good, okay? If you die, then a lot of people, other people are going to die. It'll take a while to get you replaced, okay? Calcium is about 4 units of packed RBCs is when I start considering it, okay? It's usually pretty early. A lot of people don't think of that early enough, is my biggest complaint. And what I do is I draw blood gas and draw what's called an ionized calcium level to make sure. Watch for transfusion issues. Too much crystalloids, such as lactated ringers, will induce lactic acidosis eventually, and normal saline will then cause third spacing to occur very extensively. The electrolyte problems is hypocalcemia, which is I just talked about. Hypokalemia is also very frequent, and hyponatremia can occur with lactated ringers more so than normal saline. Transfuse appropriately. In other words, transfuse when you think it's indicated.